Okay. So, dear colleagues, the last research course was on the 30th of May. We were privileged to have two outstanding faculties to enlighten us about the research question, how to define a research question, framing your hypothesis, and designing study method to address your research question. So that was what we did with the other, on the 30th of May during our first research webinar. Today, we are honored to have three blazing faculties well known in the field of research and publications. From a research question to generating data involve a series of steps that begin with identifying a research problem and formulating a clear research question, followed by planning data collection, and finally executing your choosing method to gather the required information. The process ensures that the collected data is relevant to the research question and can be used to draw a meaningful conclusion. So that's why we are here today. Our first faculty that will that will talk to us will be Dr. Esene. I don't know if he's already with us, he can share his screen.
Okay, but just before he shares the screen,
I will ask Dr. May to present Dr. Esene to us. Thank you.
Okay, thank you so much, Dr. Toponu. Before Dr. Esene will begin to share his screen, good evening to everyone, and good morning, good afternoon if you're from outside Africa. Thank you so much for joining in our research webinar for today. Dr. Toponu has already given us a good introduction to what we are doing today. I'm standing in on behalf of the chair of the Young African Neurosurgeons Forum, which is Dr. Kabulo. The Congress of African Neurosurgical Societies have just finished a congress in Ivory Coast, and so most of our key members are currently in transit. So the president of CAANS is unavoidably absent on this meeting. The Secretary General of CAANS is unavoidably absent in this meeting, and the chair of the Young African Neurosurgeons Forum is also unavoidably absent. But we want to welcome everybody to this webinar tonight.
I think that May is having some issue with the connection. So as she was saying, we are welcoming everyone with us here to tonight, and I believe she will come back when the connection will be more stable. All the colleagues that have attended the Joint Congress of CAANS, of Neurosurgical Societies of French-speaking countries, and also for SNOSA, all the colleagues that have been in Ivory Coast for this Joint Congress, they are actually right now going back to their different places. So that's the message she was giving to us. Thank you so much. Our first speaker is Dr. Esene. Dr. Esene is a trailblazing Cameroonian neurosurgeon scientist whose influence spans continent and disciplines. He is known for combining clinical excellence with humanitarian commitment and groundbreaking research. Dr. Esene is well known. He is a big brother for those that are with us and you know who he hold a Master of Science degree, a PhD, a Master of Public Health degree for several postgraduate diploma. He completed his neurosurgery residency with a PhD in Cairo. He's supported by the World Federation of Neurosurgical Society. He's a senior lecturer in neurosurgery at the University of Bamenda in Cameroon. He founded the first neurosurgical care unit in North Cameroon, improving access to brain and spine surgery. He leads initiatives in pediatric neurosurgery and neurostimulation training across African universities. Dr. Esene is a co-founder of the Pan-African Medical Journal, Clinical Medicine. He's an active mentor and educator, inspiring young neurosurgeons across Africa and beyond. Welcome to you, sir. Dr. Esene.
Thank you so much, Dr. Hugh.
Thank you for being with us. Thank you so much.
Yeah, thank you so much. It's quite an honor for me to be here with you this afternoon again. And I want to sincerely thank all the Young Neurosurgeons team for putting up this research webinar, which has been going on for a few years now, and the goal being to improve on the research in Africa. So last month we talked about developing a research question and study design. Today we're talking about data collection methods and measurement. So I'll start by using a very practical example. The people speaking on the background. So
yeah, I've got his back already. Please close your mic if you are not.
Yeah, so I'm going to start by showing you this example, this data that was sent to me to analyze. So if you look at this data, look at the age, the way the age variable was entered into the Excel sheet. You see that it's not entered in the right way. The first, for case number 1, was written 21 years, the other one 55 years. So it is not homogeneous. When data is entered in this way, it becomes very difficult to analyze it statistically. You need a lot of time to do cleaning of the data before analyzing. Same for sex. See, it is not homogeneously entered into the Excel sheet. Education, you see, there's no standardized way of entering education in the sheet. So the authors, the researchers didn't actually enter the data correctly. Similarly for occupation, you look at the comorbidity, see yes, no, and then DM, you see it is really very heterogeneous. Another example of data that was collected and sent for statistical analysis, here, look at the diagnosis. The diagnosis is not homogeneous, it was not well defined before the study was done. So you see data is entered in a very heterogeneous way. Operating time, you see the unit of measurement is not accurate, some in minutes, some in hours. So it becomes very difficult for the statistician, especially if you have very large data. Similarly for blood loss. So when you have data, or when you want to collect data for research, you have to define what you want to collect, and you have to define the unit of measurement. You have to have at the back of your mind how this data is going to be analyzed to answer the questions, the research question which you have at hand. This leads us to the topic of statistics. You know, statistics is part of a field, of a broader field known as data science. Data science is very wide, involves a lot of other sub-fields, okay? But the field we're going to start focusing on today is that of statistics. Statistics is very important, and data is very much important because we always say if you're not able to measure something, then it's difficult for you to manage it. And if you cannot manage it, it's difficult for you to be able to improve on it. So therefore, and if you don't have data, then all you're saying is just an opinion. Today, we're going to be looking at data, and we will define the concept of data, variables, how data collection methods, how to operationalize data, and what instruments can be used to collect data, and I'll give some real-world examples. And this is based on the paper which we published about a few years back. So what is data? You know, when you want to do research, you want to have information about a particular population, you want to need information about the population, but because of limited resources, be them workforce, be them money, and so on and so forth, you cannot study the whole population. Therefore, you extract a sample through sampling. From the sample, you get statistics, and then through the process of inference, you then apply the results of you got from the statistics to the wider population. This can only be possible if you are able to collect appropriate data. So data is information which you collect from the population in question, okay? And the subjects we are studying are called individuals. The characteristic of the subjects which we are measuring are what we call the variables. So when you collect data and you analyze, you can present it in the form of pictures, what we call graphs, okay? Or you can analyze it in numbers, and we call it statistics. So we're going to talk about the statistics of data today. We saw this equation when we were started secondary school, okay? When you want to study the relationship between two things, one is known as a dependent, the other is known as independent variable. For us neurosurgeons, we want to measure an outcome. We want to answer a research question, and we have our outcome. We want to see the factors that are going to influence the outcome. These factors are called the predictors, okay, the explanatory variables or the independent variables. Our outcome is otherwise known as the response variable or the dependent variable. It is dependent because other factors, other variables are going to explain or influence the way it varies. So for example, this is an example of dependent variables. You want to maybe see tumor recurrence using 2 surgical techniques. You want to see what is the mortality rate. You want to see the cure rate after maybe radiotherapy, chemotherapy. So these are dependent variables, okay? Independent variables can be socio-demographic, can be clinical, it can be related to therapy, and prognosis. So you need to know which variables are dependent and which variables are independent before you start doing a statistical analysis. Let me give an example here. Let's assume that we want to investigate the effect of a new medication on intracranial pressure, okay? So this new medication is given to subjects, and then we measure the intracranial pressure. Intracranial pressure is the dependent variable, whereas the new medication is the independent variable, because we give the medication to so many people and then measure the intracranial pressure at the end to see if there's going to be a change in the intracranial pressure based on the medication given to the patient. So what kind of data do we collect? You need to know before you, as I said, before you start your research, you need to understand the kind of data which you need to know which kind of variables you are going to have. Variables are generally classified as quantitative or qualitative. Quantitative, that is numerical variables, and then qualitative, that is categorical variables. When you go to categorical variables, they are further classified into what you call nominal or non-ordered. Here we have no units, we have ordered or ordinal variables. Let me give an example. If you want to measure, for example, the blood group, or you want to maybe have data about the blood group or the sex, okay, sex is not order. You can say male, female, or female, male. So it makes no difference if you say male, female, or male, female. If you take the blood group, you can say AB, okay, AB, O. You can say O, AB, A, and B. So the order doesn't really matter, okay, and there's no unit of measurement. If you go to ordinal data, for example, the stage of the disease, the severity of the pain, it's true that we don't have any unit for measurement of pain, okay, but it is ordered. For example, you can say mild pain, moderate pain, severe pain, okay? The stage of the disease, it can be, okay, mild, moderate, severe. So here, you see, it is categorical, but it is ordered compared to the nominal data, which is not ordered. This is very important because the statistics we can do depend on the kind of variables which we've measured, okay? When our data is limited to nominal data, we can measure just the mode. But when you go to, if it is ordered, we can measure just the mode and the median. When we go to the higher level now, which is the numerical variable or the quantitative variables, it can be discrete or counts. For example, the number of cases of brain tumor. It can be continuous variables. For example, it can have the weight, duration of surgery, length of hospital stay. So when we're collecting data for research, we prefer to have data to be in the form of continuous or discrete variable because we have many statistical tests can be done to obtain as much information as much as possible from the data collected. So we say data can be non-ordered, ordered, it can be discrete, or it can be continuous. Sometimes we have continuous data, we can recategorize it to make it to be, can be non-ordered or it can be ordered. For example, if you collect data, say the hemoglobin level, okay, 5, 6.5, 7, 8, 9, we can decide to recategorize it as mild, moderate, severe. Okay, so the data which was initially continuous becomes ordered. Okay, we can just decide to say, take a cutoff value, say hemoglobin less than this is patient said to be anemic or not. So in that case, now it's going to be non-ordered. So, but it's preferable to have your data as continuous data. Then later on during the process of statistical analysis, you can then recategorize it. So this brings us to the concept of level of measurement. So the level of measurement varies from nominal through ordinal, interval to ratio. The preferred data collection, the preferred data which we need to have when doing research is the ratio, because with the ratio data, we can do as many statistical tests as possible. Whereas if the data is nominal, we're limited to just things like the mode, as I said before. So when you go to nominal data, for example, country, if you are doing some research about Africa, you want to look at the countries in Africa. It doesn't make any difference if you say Cameroon, Nigeria, Egypt, Nigeria, Cameroon. Okay, this is nominal data. If you look at, say, the blood type, which I mentioned before, the sex, so it doesn't matter if you say male, female, female, male. Here, with nominal data, we are limited. The only statistics we can do here is the mode. Okay, it's not possible to calculate the mean, the median. We cannot do the standard, cannot calculate the standard deviation. So because these are going to be meaningless. When you move to the higher level, okay, of other data, for example, levels of education, okay, it's true that they are categorized, but the difference, for example, between elementary school and secondary school is not the same as post-secondary and graduate. You see, it is ordered by the difference between the different categories is not the same. the difference between low income, middle income, and high income is not the same. The difference between, for example, if you categorize the level of income from, say, 50,000 US dollars to 50,000 to 100, more than 100, the difference between this first category and the second is not the same as second category and the third. So this is ordered, okay, but the categories are not the same. Here we can only measure the mode, okay, can also maybe calculate the median. The preferred data is interval data and ratio, and as I told you, the most preferred is ratio. But with the ratio data, we can do all the statistical analysis. Okay, we're able to do the central tendency statistics, the mode, the median, and the mean. We're able to calculate the range. We can multiply, divide, okay, and subtract. So this is a preferred method of data collection. It's true that there are certain data which can only be collected in the form of categorical variables, but we prefer to have it in the form of ratio. So when you are collecting your data, as I said, the preferred method is to have it in the form of ratio. Later on, during statistical analysis, you can then recategorize it into different forms. For example, you can have a hemoglobin level. You can decide to say just yes, no, is there anemia or not? Or you can decide to classify anemia as normal, mild, moderate, severe. So depending on the cut-off values which you have. So having known the different kinds of variables we have when dealing with data, what are the different sources of data that we have? The sources of data that we have to collect our data will vary, and there's no best way of collecting data, okay? Because the method we use in collecting data depends on the kind of research question we want to answer. But we have to make sure that the data collected is accurate, so we don't have false information about the population we want to study. So when collecting data, we want to have to understand that data collection plays a key role in the overall success of the research, and this determines the internal validity of the study we want to. And the choice or the method in which we use in collecting data will depend on the research question, depends on the kind of information which we want to obtain, the resources which we have, and also the time. Data collection methods can be primary or secondary. And primary data collection is the data which we collect from the subjects. Okay, for example, we want to study maybe about hydrocephalus. We get patients having hydrocephalus. We interrogate them, collect data about their age, sex, the perinatal history, and so on and so forth. This is primary data collection. Whereas secondary data collection is data that has been used in the past. The commonest which we know about is maybe data used in meta-analysis. So, for example, in a meta-analysis, you use data that has been published, okay, in primary studies. You extract this data and then reanalyze. So this is not primary data collection. This is secondary data collection. So, and primary data collection is what we call the raw data, and it's a preferred method of data collection. But sometimes we want to maybe do summaries, or want to look at other aspects of research. We are bound to use the secondary methods of data collection. And be it primary or secondary, they can be quantitative or qualitative. So we can obtain primary data, which is based on the individuals, okay, the subjects, okay, and the subject are the unit of analysis. You can get it through observation, for example, in cross-sectional studies, cohort studies, okay, and case control studies. It can be through interviews, okay. You can design questionnaires and or can go to databases in institutions where they have databases. You can go there, extract the data, and you have data about the subjects which you want to study. When we talk about secondary data, as I said, is that the unit of analysis is not the individual, it's a group. For example, if you go to the council, okay, you want to get data about smoking, about alcohol drinking in the town, about the amount of meat consumed, okay, this is getting data about the group, maybe data collected through a census at the level of the national level. This is not data about the individual subjects, about the groups who want to see the general trends, see the secular trends, and see and also analyze and see what is actually happening. And as I said, secondary data can be collected from published data already. You can go to online databases like WHO. You can go to the Ministry of Health, okay, or you can go to past research. So if you go to past primary research, you can extract data from there, reanalyze, and gives us information. This becomes a secondary data. So there are two terminologies which we need to understand: the word registry, or a data bank, and then repository. Okay, so when you collect, for example, clinical data, okay, data about patients' clinical findings, data about radiological findings, about theater, you go to the operating room and collect data about the operations. This kind of data is known as the data bank or registries. But when you obtain data, for example, you collect CSF samples, tissue samples, blood samples, urine samples, and you store them in the fridge, maybe for research purposes. They talk about a repository. So these are terminologies which we need to understand when you are conducting research. So once you've collected your data, you need to understand the concept of operationalization of data. You need to operationalize your data. What do I mean by that? You need to define the concept, okay, and then define the key terminologies, because the kind of data you have or the way you analyze the data depends on the definition which you included in your methodology. For example, if you want to study traumatic brain injuries following road traffic accident, you need to define what you mean by a road traffic accident, okay? You need to define where information is going to be gotten. You're not going to get information maybe from the national level, maybe just from a particular region, okay? You need to define that before the data is collected. And you need to explain this very clearly, because if you're collecting data from the urban area, it might be different from data in the rural area. In urban areas, in most settings in Africa, you might have road traffic accidents occurring from cars. Whereas maybe if you go to the rural areas, you might get them from bikes. So these concepts need to be defined. So this is the concept definition, okay, and definition of the terms. If you're talking about road traffic accident, you need to define what do you mean by road traffic accident. What is a vehicle? Okay, who is a pedestrian? Pedestrian, is it somebody walking, okay, on foot, or somebody maybe on a bike and a seat? So all these concepts need to be defined. If they are not defined appropriately, you might collect the wrong data and draw wrong conclusions. Let me give another example about brain tumors. If you want to talk about brain cancers, you need to define what you mean by a malignant tumor, a benign tumor. Okay, how are you going to diagnose? How are you going to consider a case of a brain tumor? Is it histological diagnosis? Okay, is it immunohistochemistry or other means? These have to be defined in the protocol for your research, and you have to know if the kind of the scale which you are going to use, is it a dichotomous scale, is it a continuous scale, and so on and so forth. So these concepts need to be defined before you do your research. Let me take a practical example in a study which we did. Okay, it was a multi-center study, okay, looking at the outcome of infection after the patient for hydrocephalus. Last month we talked about defining the research question. We recommended that when defining the research question, it's most appropriate to use the PICOS format. That is P for the problem or for the population you are studying, I for the intervention, C for the comparator, O for the outcome, T for the time frame, S for the settings or the study design. So also, when you're collecting data, there's a relationship between the statistics and the study design. You also have to follow the same format, okay? So the problem is children having hydrocephalus. They operated through a technique or a ventriculoperitoneal shunt. You follow them up to see the outcome at 3 months. So we have defined the time frame. It's not outcome at 1 year, because the infection rate at maybe 1 month is different from the infection rate at 3 months. It's different from the infection rate at 1 year. Okay, and you need to define the setting. Where are you collecting this data? Are you collecting data from a rural setting, from an urban setting, in a reference hospital, in a center that is maybe specialized in treating just hydrocephalus and so on and so forth? So these have to be defined beforehand, because they are going to influence the outcome. So once you define the concept, okay, we're talking about hydrocephalus, and the subjects are the individuals are subjected to a technique known as VP shunt. Okay, now you need to define the operational terms. What do you mean by shunt infection? It has to be standardized, because a local maybe oozing from the wound, or maybe just infection around the wound, which does not lead to maybe change in the CSF parameters, will you consider as an infection or not? Okay, so this has to be defined before the data is collected. Why are you going to get the data? Are you going to see the patients, or you're just going to collect the data from the patient's file? And then again, you have to define the scale type, infection present or absent, and at what time are you measuring this infection rate? So once you've defined it, you see, it becomes very easy for you to collect your data now. The data you have to collect has to be related to the hydrocephalus, the data has to be related to the short infection, the data has to be related to the outcome has to measure at a particular point in time, and it has to measure at the different styles which you define beforehand. So the unit of measurement of the data should be very clear. You identify the patient, the age, you say age in months, sex, male, female, okay? If the birth, premature term. So these terms have to be defined. The duration of pregnancy in weeks, okay? So it cannot be measured in weeks and months at the same time, because it makes it very difficult to analyze the data when the database is very wide. Breastfeeding, yes, no, and so on and so forth. You go to the operative data, the number of days the patient had before surgery. Okay, was it first surgery, second or third or fourth? Okay, the number of surgeries that the patient had. All this has to be defined, and the unit of measurement has to be defined beforehand. Length of hospital stay, is it going to be in minutes, in hours, or in days? This has to be defined. You are trying to measure the infection rate at 3 months. So it doesn't prevent you from measuring maybe infection rate at maybe 1 week, 2 weeks, 3 weeks, because this can help you to see how this varies with time. So therefore, you measure the infection rate at different periods, but you have to be very clear that your outcome is measured at the end of the third month, and you have to say if infection is present or not based on the definition of what you consider as an infection. And then, of course, you can also associate other secondary outcomes, for example, the mortality, and so on and so forth. So once this is done, this is how you are able to collect data based on the research questions which you had, define the concepts, okay, and you operationalize your data. But to do this, you need to have a good questionnaire. You need to collect data using a tool which is called a questionnaire. Okay, I'm not going to go into much details because if the questionnaire is not well defined, pre-tested, you're not going to collect the appropriate data, because sometimes you realize that during analysis there was some data that was missing because you didn't define it very well in your questionnaire. So therefore, you have to define your questionnaire in such a way that it collects all the necessary information. Sometimes you collect more than needed, okay, more information than what is needed for your research, so that sometimes you want to do a subgroup analysis, okay, or a post hoc analysis. You can still go back to the questionnaire and extract the data. For example, if you want to measure, say, the outcome after traumatic brain injury, you have to know, okay, maybe say you are going to use the Glasgow Coma Scale or the Glasgow Outcome Scale, the extended Glasgow Outcome Scale. So these things have to define the tool which you need to use in measuring your outcome has to be standardized, and this has to be tool which is well validated. Okay, if you're using the visual analog scale, you need to teach the patient to understand how to actually use it. Okay, you're using the Likert scale maybe for patient satisfaction and so on and so forth. So to be able to collect good data, you need to have a good research question, okay? And you need to design a good questionnaire which has good face and content validity, okay? The question should be very clear and simple and very easy to answer, okay? You always start with easy questions and before going to the difficult questions, and you always make sure that you test your questionnaire before applying it to the study proper. So before I conclude, when you are collecting data, think about the statistics which you need to do at the end. Last month, I emphasized on this. There's a relationship between the study design, the statistics which you need to collect, and there's a relationship between the statistics and the study design and the concept of evidence-based medicine. Because at the end of the day, when we collect data, okay, based on the study design which we have, at the end, we have information. We need to transform this information to patient care through the process of evidence-based medicine. So we need to have all this at the back of our mind before collecting our data. So therefore, to conclude, there are some multiple sources of collecting data, okay? And we need to know that to collect good, accurate data, we need to operationalize the data collection, define concepts, okay, with clear endpoints, with the units well defined, okay? And the questionnaire which we use in collecting our data should be pre-tested, and it should be very valid, so that at the end of the day, we're able to collect appropriate data, analyze, and have the desired results. Thank you so much.
Okay, thank you, Dr. Esene. As usual, great lecture from a great man. Thank you so much. We are pleased to have you. We will be having you all along, and thanks for your availability, because I have to say it. This presentation was not for Dr. Esene, but we were stuck with some other faculties that were not available, and willingly Dr. Esene, as usual, he's always there for us. We thank him a lot for this great lecture. As you can see, Dr. Esene has underlined very important things. You need to have the best research question, because a good research question will definitely make you to look for a kind of good method to go about it, the study design, and this study design will make you to know which kind of data you are going to collect. And he has stressed also, he underlined the operationality of data and the variables. So in case you missed the first lecture, you need to I will encourage you to go through it, because all things are from the research questions. When you ask the research question, he has said it at the end. Research question, study design, and it will be followed by the data collection. Which data are you going to collect to be able to allow the person that will do the data analysis to have something concrete to analyze, which will lead to the answer you will get for your research question. So thank you so much, Dr. Esene. Thanks a lot. If you have any questions, dear colleagues, please write in the chat. At the end of the session, we will have a roundup of question and answer. In case you want to ask your question directly, you will be allowed to open your mic and ask your question. So we will head to the second speaker. Dr. Esene, thank you so much.
You're welcome.
We will continue with our second speaker, which will be Dr. Tigis. I don't know if I'm pronouncing the name very well. Dr. Tigis is from Ethiopia. Before we continue, allow me to acknowledge the presence among us of Colonel Pipezo, who is the director of Military Teaching Hospital of Parakou, Colonel Azolekon, the great pediatrician and researcher, and also allow me to acknowledge the presence among us of Colonel Sise. Thank you so much. Thank you for joining us. To make it short, Dr. Tigis, are you with us? Hello?
Yes, can you hear me?
Yeah, I can hear you. Thank you so much. Now that then let's dive into infrastructure and support to generate data, how to set up a registry and database, what are the major software in research, and the role of resident also, and the senior author, you know. So we will debate all these issues with Dr. Tigis. Dr. Tigis, I have to say, she's a distinguished Ethiopian medical doctor and public health specialist known for her impactful work in research, mentorship, and ethical leadership in healthcare. She's the founder of she's the founder and the general manager of Medical Research Launch Trading PLC, a consultancy on the training center focused on advancing medical research in Ethiopia. She's also an honorary professor of public health in the Department of Internal Medicine at St. Paul Hospital Millennium Medical College, where she mentors postgraduate clinical specialty programs. She's the chairperson of the Institutional Research Ethics Review Committee of the Ethiopian Medical Association, promoting ethical standards in medical research. She has authored numerous studies with a valuable contribution into the public health challenge in research limited setting. Her work bridge clinical practice, academic mentorship, and ethical research, making her a key figure in Ethiopia's medical and public health landscape, I must say it, in the whole Africa and all over Africa. Dr. Tigis' dedication to medical research and public health make her an invaluable addition to our conference. That's why we searched for her, and we went to Ethiopia to go and get such. We are honored to have you, Dr. Tigis. I don't know if I'm pronouncing the name very well. Thank you
very much.
Okay. Am I pronouncing the name very well?
Okay. Yes. Thank you very much.
So, Dr. Tigis, thank you so much. Thank you for accepting our invitation, and you have the floor.
Okay, thank you very much for the generous introduction. And I'd like to begin by expressing my sincere gratitude to the executives of the Young African Neurosurgeons Forum for this kind invitation to speak and contribute to the research webinar. It's very exciting that as a clinical practitioners that you have such a webinar platform where you can share lessons in research so that you can improve the neurosurgical care, and I'm really glad to be a part of it. So my presentation today will focus on infrastructure and support to generate data. Since the time is very short and there are other presentations as well, I am going to cover just the general aspect of this topic, and if there is a need to go in depth, including the statistical aspect, we can cover that in the future. So for today, just expect a very gross overview of what are the available infrastructures and support to generate data. So in this lecture, I'll cover 4 key areas. First, the essentials of setting up effective registries and databases. Second, what are the crucial software tools that streamline research and manuscript writing? Third, the vital roles of different team members from residents to authors in contributing to a collaborative and multi-center research works. And finally, we will try to see that the various kinds and source of data that are available to us that we can use and generate some evidence to the research community. So to start with, why are registries and databases so important? So in our daily clinical practice, normally we learn from individual patient experiences, right? But when to truly advance neurosurgical care, we need to go beyond individual cases and have a comprehensive understanding of disease patterns, treatment effectiveness, and patient outcomes on a larger scale. So for that, we need to have an aggregate of data from as many patients as we can. And we can access these such types of aggregate data only through registries and databases. So having this database of multiple patients will directly feed into evidence-based practice. So while international guidelines are definitely valuable, having local evidence from our own patient populations is critical. Registries help us understand what works best within our specific setting. Thereby, they can inform our clinical decisions and potentially shape local guidelines. For example, understanding the incidence and outcomes of specific brain tumors in an African population might be completely different from the data that's gathered in the US or UK. And this is actually the problem in most African settings. We usually rely on evidence that's generated in a completely different setting where the profile of the patients and the registry system and the healthcare infrastructure is completely different. So having a registry in our own setting will definitely help us contribute to the local evidence generation and guideline development, which can be tailored to our patients. Registries are also powerful tools for quality improvement and outcome monitoring. So when we have registries, we can systematically track surgical outcomes, complication rates, or long-term functional outcomes, and we can identify areas where that can be improved and implement changes based on the data that we obtain. And finally, registries, they serve as rich data sources for future research, which is actually the thing that most researchers in Africa rely on because of resource constraints and sometimes time constraints, especially in student research projects. So these registries, once they are established, they can be revisited anytime. It can be used to answer new research questions or conduct longitudinal studies and do some comparative analysis and see if there is improvement over time or deterioration over time in our care or practice. So their importance is undeniable. So building a successful registry is not just about collecting data. It's about collecting good quality data. I think the first presenter was addressing these points while I joined. I think you already have the base that good quality data is very important. So this starts with designing a standardized data elements. This means everyone collecting data must use the exact same definition for every variable. For example, if you're tracking postoperative complications, define precisely what constitutes a surgical site infection or a new neurological deficit. So consistency is very, very important. So to make the standardization easier, we can go, whenever possible, we can use established classification systems like the ICD codes for diagnosis, or we can use validated outcome scales, or we can simply follow local guidelines or even guidelines that we use as a hospital so that we can have a consistent data and we can have a reliable research output. So next is planning effective data collection methods. This is also addressed. I'm so happy that the first presenter has addressed this thoroughly. So while paper forms might be a starting point for improved data quality, I personally strongly advocate for electronic data capture systems, as they are the gold standard in any setting. So these electronic systems include widely used research software like RateCap, which is frequently utilized in academic and research institutions and is globally supported. But they can also incorporate these simpler online tools such as ODK, Kobo Toolbox, and Google Forms, which anybody can use to develop and manage independently data, which is for a small scale research work, actually, for not a large scale work. So what I'm trying to say here is that even if we don't have access to RateCap or we don't know how to use it, we can simply go for easily available online tools, which we can access them on our drive, and we can still make our research data quality. So in general, electronic systems, they allow us to build smarter forms with built-in validation rules, ensuring that our data is entered correctly from the start. For instance, a field expecting a date won't accept a text input, or a numerical range can be enforced so that we can make sure that an error number cannot be entered in the field. So this dramatically improves data quality at the source, at the very beginning. So, which is very good. And they also offer remote accessibility, which is amazing, especially for multi-site studies. So finally, having a robust data governance and quality are non-negotiable. What this involves having a clear written protocols for data entry, data validation and cleaning process, and taking measures to ensure data security and confidentiality. So when we come to how do we get started? So first we have to have a defined, clear objective. So we don't just collect data for the sake of collecting it, right? What specific clinical questions are you trying to answer? What patient population will be included in your study? So having this clear purpose guides your entire design and will lead to a fruitful, relevant data collection, and it avoids wasting any resource in both from the institution side, and also it avoids causing any unnecessary burden on the patient side. So second, always conduct a pilot phase. This is something that most people skip because, you know, the hassle of doing research by itself is a lot. So we usually tend to stick to those mandatory phases, those phases that can be monitored by our supervisors, and we tend to skip some relevant steps which we can hide and we can just pass, but these phases will have a lot of consequences on the quality of our data. So conducting a pilot phase is very important because it will allow us to test our data collection form, our workflow, and our systems with just a handful of patients, or a single department, or even a ward. So this will help us identify and fix any unforeseen issues and help us refine the entire data collection elements, the entire questionnaire, and streamline the entire process before we commit to the full-scale implementation. It's much easier to fix errors at this stage than after collecting hundreds of records, which is usually encountered among many residents and fellow researchers, especially some elements of the tool can be collected in a wrong way, and to the extent that it cannot be salvaged, and that it require doing an entire new data collection, and which is not feasible in most scenarios, and not ethical and resource intensive. So pilot phase is a very important thing, and that should not be skipped by any researcher whenever possible. Third, we have to prioritize training, ensure that everyone involved in data collection and management is thoroughly trained on the protocols, and we have to define the data elements, and we have to make sure that they understand the tool and the software to be used for the data collection. So consistent training prevents errors. So for a larger initiative, to even see whether these trainings are helpful or not, or whether it should be improved, we can follow a phased rollout approach. That means we start with a single unit or hospital before expanding to multiple sites or establishing a larger databases like national registry. So this allows us for controlled growth and troubleshooting. So when we come to the essential softwares for research and manuscript writing, what are the available things beyond the basic spreadsheets like Excel? I mean, we can use basic spreadsheets like Excel, but they're useful for initial organization of small data sets, but research will quickly outgrow them. We need specialized software. So again, I highlight electronic data capture systems like RateCap. They're not just for data collection, but they're also useful for managing your cleaned, structured data. Particularly, these are crucial for clinical trials or large prospective studies. So when we come to the statistical software, statistical analysis, there are a number of powerful options. On the open source side, we have R and Python. These are free, incredibly versatile. softwares with huge communities supporting them. So they are constantly evolving and becoming smarter. There's also EP info of the CDC, which is freely accessible and which can be used, but it has its own limitations. So on the commercial side, we have Spaces, Tika, and SAS. These are in the industry standard softwares, but they are user-friendly with graphical interfaces, but they come with a licensing cost. And even though these are usually convenient and used by most researchers, especially Spaces and Stata, that's what I observed from my students. My recommendation is to try to learn at least one open source option for long-term sustainability and flexibility, and also to do much more sophisticated analysis. Like if we're doing a survival analysis study where we need to run a parametric model, then we definitely have to use a much more complicated softwares like R. So it's always good to learn them and use them whenever possible. So for managing truly large, complex, and relational data sets, especially if you are collecting data for a multi-center study, database management systems that use structured query language become very essential, because these are more robust than just a simple spreadsheet, because they can handle immense amounts of data efficiently. Spreadsheets, they can't handle complex data without requiring manual filtering, sorting, or using complex formulas. On the other hand, these structured query language models, they use a powerful and standardized language that can retrieve, manipulate, analyze data efficiently. So we can use these complex queries to extract very specific information from the data, which is linked across different sites in different tablets. So this is very important, especially in large prospective studies and clinical trials. So beyond data analysis, there are tools that we can use to streamline our entire research workflow, especially during manuscript writing, yes, which is the goal for every research to publish it. So the first one is using reference management software. I know these things are silly and that I'm sure most of you use them, but considering the data that I have from hundreds of students that I advise or that I taught over the past few years, most people prefer to enter the references using just manually or using just a Word document reference management system. But using these reference management softwares like Mendeley, Zotero, or Endnote, these are game changers, because they will allow us to organize our entire research papers that we have referenced or we have reviewed in one place, and they will allow us to effortlessly insert the citations into our manuscripts, and they will automatically generate bibliography in any style that we want with a single click. So this is not negotiable. These are very important because they can save us countless hours and prevent formatting errors, which is especially very important if we are like submitting the paper for publication. Referencing, proper citation, and proper style is very important for a good quality research work. So finally, for refining our manuscripts, we can further consider manuscript enhancement tools. The first one is grammar checkers. Well, grammar checkers, they're very useful and recommended to be used for authors for whom English is not their primary language, because this is language barrier is one of the commonly cited problems that reviewers or editors of journals usually give us a feedback for papers that are written by authors for whom English is not their primary language. So these are definitely relevant tools to improve our manuscripts, because when we write a manuscript with a very good methodology and it has a very good result, something that's worth communicating, we should not be prevented from publishing it just because of the way it is written and because of its poor language. So whenever possible, use grammar checkers. You can use whichever you prefer, Grammarly or any other thing. And the other is plagiarism checkers. I know, this is something that we should prevent initially. We have to be ethical and avoid plagiarism whenever possible, but still in situations where we have avoided plagiarism, it's also worth going for these checkers and checking the manuscript for integrity as a final check to elevate the quality of our research work. The other thing is research, especially in complex fields like neurosurgery, is rarely a solitary game. It's a team sport, and effective collaboration is very key to success. And this relies on some fundamental principles. So the first one is having a clear communication among all team members and a shared understanding of the research goals. You might think this is a very simple thing, but when I advise a group of researchers, I have encountered team members who have different understanding of what is being studied, what's the objective of the study, how are we going to analyze the data, how are we going to write the manuscript, like to the extent that you wouldn't believe. So having a clear communication seems easy, but it's a very important and foundational step for having a good research team. The other is having mutual respect and trust among the research team, because it's important to recognize and value each person's unique contribution. I mean, some people, they can be good at doing the hard work, like doing the analysis and writing the manuscript, and other people, their skill could be in retrieving literature and writing a good introduction for the manuscript, and other people, they could be good at just reviewing the manuscript and picking what's missing and formatting it. So each and every team member is useful, and there is no such thing as a large or small contribution, as long as everybody contributed according to their skill and put a maximum effort. And lastly, mentorship is very crucial for the growth of those who are newer to the field. Without mentorship, it's very difficult to expect the next generation of neurosurgeons to become good researchers. So mentorship should always be there whenever we do research as a team, because there are always junior and senior researchers in any research team. So let's break down the roles of each party within a research team. So for residents and postgraduate students, your contributions are foundational, because for one, you are often on the front lines of data collection and entry. So it's very important to be meticulous and accurate. And second, you play a key role in the literature review and initial data analysis and drafting sections of the manuscript. Especially this is important because most of the research that you do are based on your direct involvement with the data as part of your program fulfillment research for residency or fellowship. So most of the burden falls on you. So it's very important that you are very thorough from designing the proposal, the data collection tool, collecting the data, and drafting the manuscript. And the most important part is that program fulfillment research, student research, is a time for active learning. So you have to ask questions, seek clarifications, and build research skills while doing so. So by carefully involving in all of these activities, you'll become a fine researcher and mentor in a very short time. Well, for senior authors and faculty, your role shifts to more of leadership and guidance. So you're definitely responsible for project conceptualization and design, securing resources, finding funding or arranging equipment, or facilitating access to patient population, and mentorship, supervision. More of leadership and guidance works will fall more to your direction. So during this process, it's also important to make sure that you are a good mentor and supervisor for the successful completion of the research work and publication. When we come to the last part, there are different kinds and sources of data which are available to us for doing research. So knowing these helps you to choose the right approach for your research question. So first, we have primary data. This is the data collected specifically for your current research question. Examples include data from your own prospective patient registries that you have established in your clinic, or from a clinical trial that you're currently conducting, or a survey that you administer directly to patients. So the big pros here are that this data is precisely tailored to your question, and you have high control over its quality, which is good. But the con is that it can be time consuming and resource intensive to collect such type of data, especially when you think of the short time and limited funding you have for conducting research, which are specifically tailored for program fulfillment research. And it can be difficult in those scenarios. Second, we have secondary data. This is data that we originally collect for another purpose, but it can be reanalyzed for our research purpose. So major sources here include any electronic record data from our hospital, HMIs, electronic medical records, or any other system. These are a rich source of routine clinical data, but the challenge is that these are data that are primarily collected for clinical care and not for research purpose. So the main issue is that you face a challenge in terms of accessing quality data, because they might have missing information or lack standardization, which we say it is very important to have a standard definition for collecting data from each variable. So, and sometimes gaining access can also be an issue, especially in sensitive research. And the other is national or international registries can be used as data sources, and the other is using published research, published literature as a source of data, as a secondary data source for SRMS, systematic review and meta-analysis studies, which we can use anytime, even without going through the hassle of securing ethical clearance and other consent issues. So here the pros of using secondary data are that it's more cost effective and rarely available, and it will allow us for conducting large scale studies readily. But the disadvantage is that it might not be perfectly fit for our research purpose, for our research question. And we definitely have limited control over the original data collection and quality, which can highly likely bias our study. So where do you find this data? So my recommendation is that always start close to home. Your own clinical practice and department are excellent source of primary data collection. And the good thing is that you can control the variables, you can control the quality of data. If you put a minimum, not a maximum, I mean, if you put a minimum effort to standardize it, you can have a good data without going far. Then you can look into institutional electronic health registry systems, or HMIs or AMR system. And we can also take a look at the regional or national neurosurgical registries if they are available. We can leverage them, or if they're not available, well, now it's time to initiate that. We can start small and we can grow it into a big data source that can be utilized by everyone. And finally, we can consider collaborative networks, partnering with other hospitals, universities, or even international centers. And we can significantly expand our data pool and use it for current research and for future prospective research. So to wrap up, remember the key takeaways for generating robust data. The first one is infrastructure. It's important to invest and design robust data collection systems using electronic data capture platforms. And when it comes to software, well, don't shy away from using specialized tools. They might seem daunting at first, but mastering this statistical software and reference managers will dramatically improve the efficiency and quality of your research output. So go for it. I mean, especially for statistical softwares, go for it and enjoy the things that you can do with your data. Third is collaboration. So we said research is a teamwork. Make sure to define clear roles, foster mutual respect, and always prioritize mentorship within the team. And the last is data awareness. Understand the different kinds of data that are available within our field and where we can obtain them, and choose the most appropriate that suits your research question. So thank you very much. I hope I didn't take too much time. So thank you for listening. I'll leave the floor for question and answer. Thank you.
Dr. Tigis, thank you so much. Thank you. You were very much right for doing all the necessary to get you along this course. Thank you so much. Dr. Tigis is the chairperson of the Institutional Research Ethics Review Committee of the Ethiopian Medical Association, promoting ethical standard in medical research. She's also the founder and general manager of medical research launch Sweden. She has underlined many points, very important points that we need to consider in our practice. She has underlined the fact that we need to generate our own data so that we could be able to carry out research that will reflect the reality of of each country in Africa, each country in Africa. So she broadly treated the topic. She gave us many software that we can use, RedCap, open source, R, and Python. And about the open source software that is, I will add the Jamovi software, which is quite well used which is free. It's free of charge, and is pretty much used also, which is Jamovi. And she has also underlined the data management system, which are giving us some example, the SQL and the post-grain SQL, the reference managers, that we know some of them. So Dr. Chidi, thank you so much. What we can, to summarize all the things you have said, the most important thing is the mentorship. We need to be training. That's why we are here right now doing this webinar, so that the young African neurosurgeon and other fields also of science can get into this, can be very early exposed to research. So training and mentorship. Then when all these are done, collaborative work. You've mentioned that also. This is very important. We need to work together because this will lead us to have a great team. Teamwork are crucial. That's what you've written, and I think all the colleagues that are with us have gotten the message. Thank you so much once more in the name of for the young CAANS. Thank you. Some people have wrote me. They sent me a message that I've not presented myself. I'm Dr. Hugues Deponu, neurosurgeon from Benin Republic. I'm the head of department of neurosurgery at the Military Teaching Hospital in Parakou, and I'm talking here in the name of has the chairperson of a research committee of the UCAMS. So thank you. Dr. Chi, thank you so much. Thank you for being with us. In case you have any question, please write down in the chat and we'll hold your question. When we will get to the end of this session, you can open your mic, raise your hand, and ask your question. We will continue with this session and get to the last presentation of the day. It will be with Dr. Tonya Taylor, that we got from the United States of America. We will get to know with her how to obtain the study approval, the science review, the robust science, the human ethics review, the importance of human ethics. How do we handle the vulnerable patients or population, the informed consent? So how do we handle all those situations? Dr. Tonya, she's a PhD Master of Science. She's an assistant professor in the College of Medicine at Sunny Downstate Health Science University. Where she is affiliated with the Special Treatment and Research Program. What to say, Dr. Tonya Taylor is a co-investigator in the multi-center AIDS cohort study, Women Inter-Agency HIV study, combined cohort study, and she's a co-director of the Brooklyn Initiative to Develop Geriatrics education bridge and geriatric workforce enhancement program. Dr. Tonya has over 20 years of experience in the design and implementation of ethnography, survey, and qualitative research in the United States and Southern and Eastern Africa. Her intellectual interests range across medical and linguistic anthropology with a substantive focus on HIV because she did her PhD in the Center of HIV Research. Dr. Tonya endeavored to be a leader in the area of culturally appropriate community-based approach to address health disparities in case and treatment among older adults and people living with HIV and AIDS in the United States of America and in Africa. In 2005, Dr. Taylor received a joint doctorate in anthropology and folklore with a certificate in African studies from the University of Pennsylvania. Dr. Tonya, thank you so much for being with us. She has published many papers and she has authored and written many chapters of books also. Dr. Tonya, are you with us?
I am.
Okay.
Can everyone see my slides?
Yes, we can see your slide. Thank you so much for being with us. We know you are very busy and your schedule also, and the time right now in the US that you try to make it. Thank you so much. We are grateful. Thanks a lot.
It is absolutely my pleasure. Good afternoon, everyone. My name, thank you very much for that also generous introduction. So today I've been tasked with doing a simple overview on the importance of obtaining study approval and to talk about the science and the ethics. First, let me just say that regarding conflicts of interest, I do not have any disclosures. However, what I'd like to do is I'd also like to acknowledge my dear colleague, Dr. Ernest Barthelemy, who is a neurosurgeon at SUNY Downstate and also Brookdale Hospital. And he is actually sort of my connection into the world of neurosurgery and TBIs. And so I am really grateful to be able to help my wonderful partner in crime who is at this moment doing neurosurgery. Dr. Barthelemy and I share a particular mentor who is Paul Farmer, who sadly passed away years ago. And we'd like to start off our presentation, which I think is just on time, especially right now with the chaos that is happening in our country. This is a quote from Paul Farmer. The idea that some lives matter less is the root of all that is wrong with the world. And both Dr. Bartholomew and myself, this is our sort of modus operandi in the work that we do to address not just local, but also global disparities. So briefly, this is what I'm going to try to do quickly. I'm going to present an overview, talk about our learning objectives, why approvals matter, talk about the scientific review, the ethic review, talk about vulnerable populations, informed consent, what is informed consent, and assent. And there's going to be a little bit of an interaction here. And so I hope that people will unmute themselves and we can have a little bit of a discussion around a hypothetical case study. And then we'll wrap up. So our learning objectives. Today, I'm hoping that by the end of this little presentation that you will understand the dual review process for research approval. There is a scientific review, and then which basically constitutes or ensures that there is robust science. And then there's also a human ethics review in terms of protecting participants. We're going to discuss considerations for vulnerable populations and review informed consent and assent principles. I failed to mention at the beginning that I was a member of my institution's IRB committee for over a decade. My institution at one point had one IRB institutional review board. one committee which did both the scientific review and the ethical review. In recent years, we have tried to separate that and have one committee do the scientific review, and then for the broader meeting, we discuss the human ethics. Why are approvals important? I just a quick little anecdote. When I started working at SUNY Downstate, a young man said, "Hey, I've got some data. I want to talk to you about this data." And it was qualitative data. I'm a mixed methodologist, and qualitative data is absolutely my area of expertise. And I met with him in the cafeteria, and we went over his data. And in addition to him absolutely fumbling in terms of collecting qualitative data, i.e., he basically answered, he asked respondents a question and then he would answer if he didn't like the clarity and the details of what the respondent said. You can't publish that. That's not their words, that's your words. But at the end of our conversation, I sadly discovered that he had not received any IRB approval, that he had just, as a provider, decided to do this study. And unfortunately, no one in his department had been able to give him any feedback. And perhaps maybe he didn't even ask. Because if you don't have IRB approval, retrospectively, you can't really get IRB approval. Sometimes you might be allowed to do that if you're still prospectively collecting stuff. But if the data has already been collected and you didn't get IRB approval, it's very tricky. So why do we need to go through all of these steps? Number one, we have to go through these steps to make sure that that the science is tight, to ensure scientific validity and ethical integrity. For a lot of journals, you can't publish if you don't actually acknowledge that you've gone through this process. More importantly, from my perspective, sitting on an IRB, IRB is all about protecting participants. I'm an anthropologist, so my research is very patient close. And so for me, making sure that we're doing no harm to our participants, our respondents, is paramount for me. For a lot of places, depending in terms of funding, it is absolutely required, as I mentioned also with publication. And the thing that it does the most is that it helps to enhance public trust of the research process. So scientific review, what happens here? Some institutions might have just one committee. They might have a committee for the science review and then a committee for the ethical review. But what happens usually in a scientific review is a thorough sort of vetting of the protocol regarding the research question, regarding the rationale. I know that sounds like something that shouldn't be scrutinized, but there's a lot of spurious research out there that's really not doing any good. And people have different motivations for research. One of which is that they have a serious conflict of interest in terms of trying to promote something that doesn't necessarily have a therapeutic benefit, but they might down the road have a financial benefit. And so it's really important for these committees to sort of sit and to think about, what is the research question? Has it been mapped out clearly? Often the protocols that I've seen were just not mapped out clearly, and it took a lot of work to try to get our investigators to clearly, map out and writing what it is that they wanted to do, what was their objective, what were their hypotheses, and so forth, and the rationale. Study design is also something that sadly I've seen a lot of proposals where there wasn't enough information in detail, and we will absolutely send a protocol back. If you haven't mapped out all of the steps, what that is saying to us is that you don't have a clear map. It's not clear. I'm sorry, I'm probably not being clear in my language. If you are not able to, have step by step what you are doing in terms of recruitment, in terms of administering consent, in terms of how the procedures or the study components are going to be rolled out. That's a big flag for us that conceptually you're not clear in your methods. And one of the reasons why we need to make sure that this is clearly spelled out is regarding protocol violations. So if you say that you're going to do something and then you decide midstream that you're going to switch things, that requires what we call an amendment. You have to be honest and straight up with the institutions to let them know, okay, we discovered that our recruitment procedures are not effective, and so we have switched our recruitment strategy for X, Y, and Z. And you put in an amendment, and it is amended. And you want to do that. You never ever want to skip over amendments. Amendments are us um, um, making sure that we are honest about the research that we're doing. Feasibility also under scientific review. There is an assessment in terms of feasibility. Are folks proposing something that is just not feasible within, for example, the institutional or constraints of a particular clinic, and maybe they've never ever conducted research before, and we need to tell them, how are you going to do this? There's no private room to be able to consent people, or how are you going to do this if you're going to then dump all this work and responsibility on a nurse whose job is not to conduct research. And then finally, thinking about safety and risk in terms of, and safety and risk is considered in two places, both the scientific review as well as the ethical review, but because safety and risk are paramount to making sure that we do no harm to our participants. Characteristics of robust science. In the previous slide, I mentioned that the reason why we need to have a scientific review is to ensure that our science is tight, that it is robust. We need to make sure that there is a clear hypothesis with clinical or scientific relevance. We need to make sure that our methodology is sound, that it makes sense in terms of what type of data you're trying to collect and what you're going to ultimately do with that data, and that you have enumerated every single step. Also, there are within the scientific review, there are scrutin, statistical sort of scrutiny over sample size, your method of analysis, etc. There's also making sure that this is reproducible, and that there is transparency in the methods and in the science that you are proposing. And again, more sort of emphasis on sort of the statistical analysis. Do you have enough power, and have you done enough to minimize bias? The role of human ethics committees is a little bit different. So again, as I mentioned before, this is at least one of the reasons why I loved being on an IRB. And let me just say this also, if you don't have a lot of expertise around this area, please volunteer. Find out if your institution, if they are looking for volunteers for people to sit on the IRB. One of the ways in which I learned so much about study approvals is because I volunteered to sit on an IRB and to sit and to learn. And over 10 years, I learned a lot. Specifically about how to get protocols like move through our process at downstate, but just in general, in terms of the bigger picture around, beneficence and so forth in terms of human trials. But our first goal in terms of an ethical review is to make sure that we are safeguarding, we are protecting our participants, respondents, in terms of their rights, dignity, and to make sure that we are doing no harm. That is, for me, most important. We also need to make sure that it has been clearly mapped out for any potential participant or respondent that this is voluntary. All research is voluntary. And if people don't say that, that is a form of coercion. And so this is one of the fundamental requirements in research is to make sure that participants know that they don't have to do this. Okay, and that is all mapped out within the an effective and correct implementation of an informed consent. Under the human ethics domain, our goal is ultimately to protect, promote justice and equity in research. For some of you outside of the United States, I hope that you have all heard of the horrific legacy of Tuskegee and how this is profoundly affected Black and Brown individuals. And there are other examples as well, especially with Native Americans, Indigenous Americans to the United States in terms of being used unethically in human research. And so we are the gatekeepers to make sure that no harm is done to communities, individuals, etc., and to make sure that there is justice and equity. And finally, again, coming back to, as I mentioned with the scientific review, to make sure that we have thoroughly thought through and evaluated the risk and benefits of participating in this study to make sure that that ratio is equitable. As our moderator mentioned, one of the things that we are absolutely covering under this overview is that you might be working with a vulnerable population. And if you are working with a vulnerable population, that means that additional components or additional aspects of your protocol need to be considered. Okay, because we need to make sure that in addition to them understanding that research is voluntary, that they don't have to do this, that this is not going to impact their ability to continue to receive care and treatment. That it's very, very specific that we make sure that there's no coercion or undue influence. And one of the things that is often um, a variable that we look at is, if participants are going to be incentivized, is that incentive so large that it becomes coercive? If you are working with a population that is socioeconomically challenged, right, or disadvantaged, waving around and saying, if you do this particular study, I'll give you $800 might be considered coercive. So particular vulnerable populations, if you're working with them, there are very specific things and guidelines that will then need to be included to make sure that you are protecting and not coercing or putting undue influence on these populations. And those vulnerable populations include children, people who are incarcerated, prisoners, pregnant women, individuals who are cognitively impaired, which could include intellectual disabilities, as well as older adults who might have mild forms of cognitive impairment, and of course, socioeconomically disadvantaged communities. My primary population in both Africa and the United States are people living with HIV, which is an extremely vulnerable population regarding protecting their PHI to make sure that the information is I'm sorry, I just moved, so I'm really tired. To make sure that we are protecting their personal information, that their status is not going to be shared or disclosed in an inappropriate way. And so that is just another vulnerable population. I should say also like homeless individuals are also considered a super vulnerable population. Now, informed consent. Whenever I administer an informed consent, I tell my potential participants that if they don't see someone, if someone comes to you and says, "Hey, I want you to do some research," and they don't have a piece of paper like this, and they don't talk to you like I'm talking to you about what's going on with this piece of paper, run for the hills. Because an informed consent is basically a sign that you are doing everything that you can to make sure that you're doing good and ethical research, okay? First and foremost, I mean, I've seen even my colleagues hand people a piece of paper and say, just sign here. And that is not administering informed consent correctly. What you need to do is you need to go through and no, you don't have to read everything. You want to basically paraphrase the big sections in terms of what is most important, like who's doing it, what's going on, etc. If you read the full thing, you're going to make people fall asleep. But you need to emphasize, number one, that this is voluntary, that respondents have a choice. They can choose to participate or choose not to, and that is really, really, really key. In an informed consent, when you go over it, you need to make sure that you are very clear about what's the purpose, what are the procedures, what are the risks, and what are the benefits. And you need to also discuss in depth what are you going to do to assure confidentiality and also the right to withdraw. Assent is a type of consent that is administered to individuals who cannot give full consent. Usually children, in the United States, we commonly use assent with children. However, I have also seen assent being used with older adults that have mild cognitive impairment. Usually with children, the language has to be age appropriate. So if you are doing an assent with a third grader, you need to make sure that that language is on their reading level, or that in that you're using not a lot of jargon and so forth that will be difficult for a third grader to access. And that it's very clear, not in scientific description, but in a layman's interpretation of what it is that you're doing. Assents are always accompanied by a parent or guardian informed consent. So if you are doing research with children, that means that you've got to do both an assent and an informed consent, an assent with the child and an informed consent with the adult. And, it is really, really important, the assent process, because what it is really doing is also respecting that these children that we're incorporating, inviting to participate in research are developing their own sense of autonomy in terms of what they want to do and what they don't want to do. And I think that's wonderful. So here's a workflow just sort of mapping out how it potentially could look. And this depends on your institution and the different levels of approval that you need to go through. At my institution, we would probably just stop here with an institutional scientific review committee, and that's enough of approval to be able to do a study at my institution. However, if you're working with a multi-site study, then there might be a national IRB or a broader IRB that you then have to get first institution approval at your institution, and then approval at the overarching national IRB. Sometimes there could be a next step in terms of, and I'm sorry, on this slide it says national IRB, but this should really be sort of like a multi-site IRB. And then the third level, which is sometimes required in Zimbabwe, I had to get my study also approved by the Medical Research Council, which is the National Research Authority. And I didn't have to go to the Ministry of Health in Zim. I just had to basically get my approval from my institution and then from the Medical Research Council of Zimbabwe. So, Dr. Bartholomew has asked me to do a little bit of a discussion with you. And so I hope that you will unmute yourself and chime in. So, we have a proposed observational study that includes minors with TBI from underserved communities. All right. And now I want you to think about what are some of the ethical issues that would arise. Should I come out of the screen share? Anyone want to jump in with this a suggestion?
Please open your mic.
The fact that
Yes.
Unmute yourself and please jump in.
the fact that they are minors, which means that they are probably below the age of 18, and that you would need to consult their parents or whoever is taking care of them. You need to seek consent from them before you can go ahead with your project. And so the fact that they are minors means that you need to seek some sort of consent from their parents.
Absolutely. Okay, so first things that, we can't approach this minor by themselves, that we have to include the parent or guardian. What's another potential ethical issue that would arise here?
So thank you. I'm thinking about considering it's in underserved communities. There will be issues surrounding coercion. So sometimes some of these patients may not want to participate except if you incentivize them. So there'll be some issues around coercion.
Thank you, Abbas. Thank you. Okay, you guys, I should have mentioned that there are potentially 4 things that we could talk about. So we've got the consent and including parents. We have the component about there being undue influence with an underserved population. What's another one?
Considering traumatic brain injury, it's possible
Yeah.
Hello?
Yes, keep going.
I hear you.
It's possible the consciousness of those patients may be affected, and so the cognitive function here may be affected.
Absolutely.
Therefore, they will need a guide, a guardian or parent that will come in to give the consent and also the information that will be needed for the patients.
Right. Absolutely. So, I didn't see who said that, but so another thing is that even though we absolutely are going to include the consent and assent, we also need to consider sort of, how is this TBI affecting this particular participant, in terms of their really being able to assent to this study. Okay. And I should add that there might be educational issues with the parents, and maybe that there might be some other barriers to really obtaining a truly informed consent. And there was a 4th one. And what was the 4th one? I need to almost like look at this.
Underserved community.
Yeah, someone got underserved community. So there's that they're a minor. Consideration of sort of like with the TBI, are they able to? I'm sorry?
No, please go ahead. I've muted his mic.
Okay, can I make a statement too?
Yeah, please.
Yeah.
Considering the fact that they are also underserved, one might be tempted or not be confused on whether to apply some interventions. For example, if there is an intervention you're supposed to do in order to know whether there will be a change, maybe by some medications or not, who to give medications to or not, and who not to give medications to in order to see the outcome. So if it's underserved, it might be judged as unfair, given to some people and not given to others, especially when they are underserved.
Yes, I love that. I love that. And, I'm glad that folks are thinking about different components of what it means to also do research with an underserved community. And the fact that like there's, if there's an incentive, there's like potential for coercion, but there's also the fact that the underserved community might not necessarily really understand research procedures, and so forth. And so you can't just sort of go in and just sort of say, hey, I'm doing a randomized clinical trial. And they're just like, what the heck is that? Right? So that, we also have to take into consideration where is this community in terms of understanding what is research and what it is that we're trying to do. Guys, you are awesome. Thank you. I'm going to move on here. So finally, the summary and key takeaways is that, scientific and ethical reviews are complementary. You can't do one without the other. So when you are getting an IRB approval, you need to make sure that if your institution has two separate departments, you need to make sure that you go through both, okay? And that they're both checked off. Respects for persons, beneficence, and justice must guide research. We always, from the get-go, in terms of thinking about the research we're doing, if it is unethical, if we're asking too much, if we're putting people at harm's way, should we be doing this research? I think not. Okay? Approvals are a process and not a checkbox. Okay? So just as I mentioned before, if you get a particular protocol approved and then you discover, oh, nuts, my methods in terms of recruitment is not working as I had hoped, so I need to modify this, you need to go back and you need to submit an amendment to let your institution know that this is a change that I have done in my study. And I just want to say, if like they find out that you have changed certain procedures, you can get into trouble in terms of institutional review. And so you need to always be straight up and clear with your IRB about what it is that you've changed. Okay? Ethical practices must be culturally and contextually relevant. And so in this regard, I'm thinking of the person who chimed in the last slide around the community and working with disenfranchised communities. I think that it's very, very important that when we engage with communities, that we meet them where they are, and that we also meeting them where they are might also mean that we need to do a little bit of more work and to make sure that they understand what it is that we're doing, and that we are explaining it in ways that are salient for that particular community. Here are our references. And if anyone, I don't know if I have time for anything else here, but this is my email. If you have any questions, you can email me. You want to do a quick screenshot? There we go.
Okay, thank you so much, Dr. Tonia. Thank you so much. You've gone through more than expected. You've underlined the difference between asset and consent, and I think your message has been well understood. And the IRB approval before we start any data collection. I love that because I'm a data scientist and I've been helping many neurosurgical departments to analyze their data. And sometimes, if not most of the cases, when the colleagues are sending their data, you ask them, okay, what is your research question? What is the question you are willing to provide answer to? That's when they start to think. So what is the question of the disease? You've emphasized on that aspect also, and that means we need to get data scientists along from the beginning of our study, and we need to, because you've emphasized that the research question and the rational are the first two things that you guys look at when you are in the committee or in the ethical committee. So thank you so much. You've gone through all the aspects of the topics.
I just realized that there were some questions here.
Yeah, there are some questions
from Dr. Isain. Could you please further comment on consent assent for people with cognitive impairment?
Yeah, please.
Dr.
Isain,
I hope I'm pronouncing your surname correctly. You know, this is there is no one cookie cutter for when you are dealing with individuals with mild or severe cognitive impairment. The bottom line of what I was trying to elucidate today is that that must be a part of the equation, okay? That like when you are thinking about doing assent and consent, you know, a child with TBI, then you absolutely, as the research team, need to think through, you know, what, you know, the level of cognitive impairment, like what are we doing to ensure that we are absolutely getting informed consent? What are we doing to make sure that we are providing all the information as well as the fact this is voluntary and you don't have to do it? So there is no one cookie cutter formula for how to do this. And this is for all the participants today. What this is really is I don't want to say, you know, basically a guide to make sure that as you are thinking through these, that you take into consideration, okay, I'm going to be working with some young folks. All right. I know I need to write an assent. I need to write a consent. I need to make sure that it's on the right reading level for these kids, that it's layman's language. But then in addition, okay, how do we make sure that these young kids that have mild or moderate or severe cognitive impairment, how do we make sure that that assent is understandable for a child that has this level of TBI? And that is all I was trying to say. There is no cookie cutter. It really, you know, you guys are the clinicians. You guys understand in terms of how to meet your patients where they are in terms of the level of cognitive impairment they may or may not have. And so that is something that I think really, really requires a clinical sort of lens and assessment. And you know that we have a community here, right? In terms of people that can be consulted on in terms of sort of who has done, you know, an assent or consent or assent, excuse me, for children with severe TBI. Like, what were some of the things? And so, Dr. Asin, like, you know, I really encourage you not to think about reinventing the wheel, but to build off. I love communities like this where it's like a bunch of, you know, in the United States, for me, it's like a bunch of like, you know, black and brown folks like helping each other with research. And you've created that in terms of within the African diaspora. And I love that. I'm so excited. So lean on your colleagues, your peers within this incredible, unique space to be able to figure out how I can learn from maybe my peers as they have also struggled with and maybe figured out the best way to do this.
Thank you so much. Dr.
Dr. maybe I should just take over this one. All right. We want to appreciate Dr. Taylor, Dr. Wakne, and Dr. Esene for a marvelous teaching session this evening. It has been spectacular. We are really running short of time, but we have 4 other questions that are yet to be answered. And I think maybe I'll just take 2 of them within the short time that we have before we round up. There's a question for Dr. Taylor. Are online or virtual consents acceptable in carrying out researches? The person actually asked for underserved populations, but I would just want to extend that to generally speaking, are online or virtual consents acceptable in carrying out researches? Dr. Taylor, please.
Yes. You know, during the pandemic, we absolutely had to use, I'm going to just turn off my camera in case my Wi-Fi is not good here. During the pandemic, we absolutely had to rely on online consent. I used RedCap to be able to do the online consent. I believe, and you have to actually check with your institutions, like what is permissible and what is not. There was, as of I think last year or maybe last year, In the United States, we are no longer able to use Zoom to do research, which was just awful for us because that's actually the space and place that a lot of our people here in the United States were able to get on Zoom. We have HIPAA compliant Zooms. We're able to, do informed consent and share the screen and be able to give them a link for the red cap informed consent. Doing online is absolutely possible here in the United States. I would really, really reach out to the people in your home countries or the countries you're doing work in to figure out exactly what limitations. Now, another thing about sort of virtual online consent is that there is also this huge digital divide, and that a lot of our respondents don't have, for example, a smartphone or are not able to have access to that technology to be able to do that. So, sometimes in doing research in the field, we might have the consent on a tablet where, it is linked up with our red cap and we're able to, collect it that way. But sometimes we've got to do pen and paper and
All
collect.
right. Okay, thank you. I thought she had finished. I didn't know she still had something more to say. Dr. Taylor, you want to complete your statement? I'm sorry, please.
No, I'm done. I completed it.
Okay. Okay, beautiful. Thank you so much. Thank you. Just one more question and then we'll call it a day. And I think this is a very important question, and it's also to you, Dr. Taylor. In the event of a medical legal incident, who defends the researcher?
In the event of a medical, are you talking about an adverse event? Like if in the course of doing research, something happens that hurts the participant? Is that what you're talking about?
I think the way the person put it, he just said medical legal incident. But I would say that in the context of what we are discussing, what if participant has signed the consent form, but somewhere along the line decides to sue you for one thing or the other? Who defends you as a researcher?
So my understanding is if your institution is approving this study, that they are the ones that are sort of legally responsible. It's not the individual researcher. Maybe that's not always true. Maybe an individual researcher can also be liable. I think actually both the institution and the individual researcher are probably liable. But this is around like really horrific accidents, right? And, in terms of neurosurgery, I know that, stuff can absolutely not go as planned and that, hospitals, have their insurance and to protect their surgeons and so forth. I just want to remind folks that like I'm an anthropologist. So in terms of some of these, I wish that Dr. Bartholomew was on to be able to answer some of these things in terms of sort of how to protect the neurosurgeon. But in terms of how to protect the researcher in terms of being protected would be underneath the institution. And I do think that, if they're doing bad research.
Dr. Bartholomew, is he here?
Dr. Lukuya, do you have a response?
No, he's not. I don't think he's connected.
Yeah. I wanted to give just a quick comment on ethics. I think the IRB has in general 3 dimensions. There is that scientific dimension you mentioned, the ethical dimension you mentioned. There is also what we call a legal dimension also, because sometimes data are part of the security of the country. So you cannot get any data like this. There's what we call sensible data that you cannot just get access to it. So sometimes medical legal issue can come, like extracting DNA of a certain population to do some manipulation for it. So you may end up in trouble, if the outcome of your study or later use of
Oh,
the
yeah.
data.
No,
So that's something that we can consider as a part of the medical legal aspect of our research. Thank you.
Yes, but I would include that. That is actually folded into both the scientific and the ethical. In both the scientific and the ethical components, you need to make sure that you have mapped out how you are going to protect their data. Sensitive PHI, personal health information. So, Dr. Lukua, you're absolutely right. But in terms of confidentiality, protecting sensitive data, those are all, for me, included in the protocol and are reviewed and scrutinized by both the scientific community as well as the ethical community. So the scientific, like, what are you, how are you, are you using a HIPAA compliant, platform to be able to store this data? If you're not, ding, 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 right? And, and for the ethical people, like, what are you doing? Like, how are you securing this PHI? Where is it going to be kept? Is it going to be kept in a private locked room? Is it going to be kept, where is this data going to be kept, this information? So you need to answer all of those questions. And when you're doing international stuff, I'm actually working with a colleague that is actually doing DNA research with colleagues in Nigeria. And absolutely, in terms of sharing that data, there are all kinds of protocols and safety protocols in terms of where the data is going to sit, if it is going to be shared or not shared, etc. So you're
All right.
Okay.
Yes, thank you so very much. We have had a very enriching webinar this evening, and we want to absolutely appreciate our three faculty for today, Dr. Tonya Taylor, Dr. Wakne, and Dr. Ignatius. Thank you so very much. We had real good value this evening. We also want to appreciate everybody for joining in. At a point, we had up to 59 participants on this webinar from different parts of Africa. So Dr. Taylor, you wanted to know what parts of Africa are represented here. At least on this webinar, I was able to identify people from Nigeria, from Ghana. Dr. Sene is from Cameroon. We had people from Zambia, Algeria, Ethiopia. Dr. Wakne is from Ethiopia too. So we had people from all over Africa represented here this evening. We want to appreciate all of our senior neurosurgeons present. Thank you, Dr. Lekuya, for joining in and for also airing your views as well. Thank you, Dr. Nuruddin Bakole, for being in, and all our Young CAANS ESCO. Thank you for being on the webinar this evening. Two short announcements before we call it a day. Our next Young CAANS education webinar will be coming up in August. August 23rd, same time, 4 p.m. GMT. Our flyers will be out soon and we'll publish them as soon as we have the flyers ready. And also very big announcement, there's a boot camp being organized in Lumumbashi, Congo DRC, in conjunction with the Congolese Society of Neurosurgeons and the Baroque Medical Company. It's a workshop on ICP monitoring and posterior cervical fixation. So young neurosurgeons, young African neurosurgeons, watch out for the announcement and get ready to be at Lumumbashi sometime before the end of this year. Thank you so very much, everyone, for joining in. This juncture, we'll call it a day and see you in our next webinar. Thank you and good night, everyone.
Thank you.
Merci.
Thank you.
Bye-bye.
Yeah, merci beaucoup.
Merci
Bye.
beaucoup.
Good night.